Today we will discuss about some of the specific infections, and among them we will discuss about post-transplant infections. Now, as the name suggests, we are looking at all the infective conditions which occurs in transplant patients after the transplantation is done. So let us recall a little bit about transplant immunology. So, what is a transplant? A transplant is a graft that is a part of the body, human body, which is transplanted or grafted from one place to the other. Now, from the body from which the organ is taken up is called the donor, and in whom it is placed is called as the donor. Now, based on that, we can divide into many types. First is based on the topography. Topography means position. So, we can divide into orthotopic graft or heterotopic graft. Ortho means correct or standard. So, when we are replacing an organ in the same place, we call it as orthotopic graft. For example, the skin. Any part of the skin which may be damaged, either burns or any other lesions, and when the skin is grafted over the same place, we call it as orthotopic graft. Similarly, in case of heterotopic graft, the organ is planted at a site which is different from the normal anatomical position. Furthermore, we can again divide the graft into two types based on the functions. The one type of graft is called as the vital graft, and another is called as the static graft. The vital, as the word means, that means living or performing bodily functions. For example, a renal transplant, the transplanted kidney will go on performing the functions of the kidney. That would be an example of a vital graft. However, if we do take the transplant from a bone or a cartilage transplant, it only provides the scaffolding for the position or the structure, but it does not provide any other functions. Those are called as the static grafts. Furthermore, depending on the donor, we can classify the grafts into various types. The first type is called as the autograft. Auto means taking the graft from the same body and transplanting into the same person. The next would be isograft or syngenetic graft. That means over here the donor is the genetically identical being. In case of humans, that would be twins. Furthermore, if it is taken from another individual, we call it as allograft. Over here there are some genetic differences. However, most of the time the graft can be done provided we go and check up the genetic differences. The last but not the least is also called as xenograft, when the graft is taken from an animal or an organism from a different species. So the chances of rejection will go on increasing from autograft to isograft to allograft and finally xenograft. Hence, the chances of rejection will be highest in case of xenograft and the lowest chance would be that of autograft. Now, recall little bit about the histocompatibility. Histo means tissue and compatibility means genetic compatibility. So, if the histocompatibility is there, the chances of graft rejection would be much lesser. Commonly, in case of transplant, we look at the two major types of genes. The first would be MHC molecules or major histocompatibility molecules and ABO blood group. Mismatch of both these two will most of the time result in rejection of the graft either acutely or in chronic phase. Furthermore, there is one more complex called as the minor histocompatibility antigens. They can also cause rejection, however, the probability is much lesser. So, for all practical purposes, matching is important only for the major histocompatibility complex and the ABO blood group complexes. Moving on to type of the rejection, I think it has already been covered in the immunology. Still, let us recall the graft can be rejected in three manners. The first type is called as the hyperacute rejection, then the acute rejection, finally is the chronic rejection. Proper histocompatibility, ABO matching and proper immunosuppressive therapy enables us to prevent hyperacute rejections. However, acute and chronic rejection will happen in most of the time and has to be dealt with similarly. Now, coming to the infections in the patients, we are concentrating on the infections of the patient who has received the transplant. Now, these infections can be either, as I've already said, endogenous or exogenous. When we do classify the organisms, we can look at the organisms. Commonly, in case of viruses, we have the herpes group, the hepatitis group, the retroviruses, and other viruses. As far as the bacterial agents concerned, we have the common gram-positive and gram-negative bacteria causing most of the infection in other patients, and more importantly, we have mycobacterial disease and nocardial disease, which may be caused especially because of reduction of the cell-mediated immunity. The next type of organisms which do cause infections would include the fungus. Among the funguses, commonly we have the Candida, either albicans or non-albicans, the Aspergillus, and rarely we can have Histoplasma, Coccardis, Blastomyces, etc., depending on the geographical area. Similarly, parasitic infections can also be seen, and those commonly seen would include Toxoplasmosis, trypanosomiasis, strongyloids, and leishmaniasis. Furthermore, if we look at the exposures of the infective pathogen, we can again classify them based on the place from which they have been acquired, either nosocomially or from the community. Obviously, when we are looking at community exposure, we have to look at the exposures, either food or waterborne, or respiratory viruses or common viruses. Now, if we do try to understand why these infections occur more commonly, the most important part would be the immune suppression. Now, why this immune suppression occurs? Either it is the suppression of immunity is done iatrogenically, that is for the purpose of transplantation, or because of the specific underlying conditions. So, among them, the most important causes would be immune suppressive therapies or prior therapies with chemotherapy or antimicrobials. This is very important in case of hematopoietic stem cell transplantation, where these chemotherapeutic agents are given prior to transplantation. Furthermore, other conditions like genetic polymorphisms or autoimmune diseases or any other disease which may be associated in the recipient may lead to immune suppression. As far as the iatrogenic immune suppression are concerned, there are many drugs which can lead to direct or indirect immune suppression. Many drugs, including the anti-lymphocytic globulins, procedures like plasmapheresis or corticosteroids, azathioprine, these drugs are commonly given. Hence, all these drugs will ultimately lead to suppression of the immune status, either directly, indirectly, either in the cell-mediated wing or the humoral wing, and that can predispose the recipient for further infections. Now, another aspect you have to consider in the recipients is the role of the normal microbiota. All these procedures that the recipient undergoes, which include therapeutic or procedural immune suppression or surgery or infections acquired in the hospital or antimicrobial therapy, either in prophylactic or therapeutic form, will ultimately disrupt the normal microbiome of the recipient. Now, after this disruption, the result could be twofold. The disruption is called as the microbial dysbiosis, and this dysbiosis may be recovered if the microbiome population is resilient. It can repopulate and may lead to what we call as the graft tolerance with improved graft function. However, if the microbiome is unable to recover, it may lead to alteration of the systemic immune function, which may lead to graft rejection, ischemia, inflammation. So hence, we do have to focus on restoring the normal microbiota of the recipient. Now, having said that, having understood that the main facets of transplantation, first the immunologic aspect, then the microbial role, either community or nosocomially acquired, and finally the normal microbiota role of normal microbiota in the recipients. Now we also need to screen the donors for some diseases. Why? Because whenever we are transplanting an organ, these diseases can be transmitted from the organ to the recipients. Commonly, the screening is done for the common viruses, that is the blood-borne viruses, HIV, hepatitis B, and hepatitis C. So, most of the organ donation or even stem cell transplantation may lead to transferring of this organism to the recipient. As far as the recipient is concerned, we need to screen them for many aspects. First is we have to ascertain whether the recipient already is infected or not. For that, we need to go through the medical and the familial history, occupational exposure, specific hobbies, including sexual history and vaccination history. Thereafter, we need to screen the patient for some specific organisms. This is important. What are these organisms? First would be the cytomegaloviruses, Epstein-Barr viruses, measles. We have to screen for syphilis. Then blood-borne viruses including HIV, hepatitis B, C, and retroviruses, and also toxoplasmosis. And last but not the least, we need to screen the patient for latent tuberculosis either by skin testing or interferon gamma acids. Now, this is very important because most of the time prior to the transplant, these organisms may lie dormant in the body, and post-transplant they may reactivate. So to detect the reactivation, we need to screen them prior to the procedure of transplantation. Additionally, we may have to look for herpes simplex, varicella zoster, strongyloides, and endemic fungi. Furthermore, as you are already aware of healthcare associated infections caused by multi-drug resistant organisms, we also need to screen the recipient for commensal drug resistant organisms, which would include a nasal or a skin screening for MRSA or a rectal screening for vancomycin resistant enterococci or carbapenems producing enterobacteria. And we also need to ascertain the immune status of the patients and inquire about the proper documented history of vaccination against the common diseases like hepatitis, influenza, pneumococcal vaccine, tetanus, MMR, that is mumps, measles, rubella, varicella, meningococcal, and human papilloma viruses. Now, after that, the procedure of transplantation is done. After the transplantation is done, we need to look for the infections in these patients. Now, this can be categorized into three main parts. The first part is less than 4 weeks after transplantation. Then 1 to 12 months, that is within the first year, and beyond the first year of transplantation. Why this classification has been done? Because it is seen some of the infections are more common in the first month, some infections are more common in the first year, and some infections occur after 1 year of transplantation. Now, if you look at the viral diseases, as you can see, in the first month, most of the infections or recurrence occurs due to the viruses that are present already in the donor tissue. That is the reason why screening of the donors is very important. Beyond the first month, we can see the common infections are caused by the herpes group, including varicella zoster. This is where immunization against varicella zoster and proper identification and treatment for herpes is important. Other than that, most of the viral diseases, including caused by adenovirus, BK virus, or cytomegaloviruses, these infections are seen after 12 months of exposure. Now coming to the other organisms, as you can see in fungal, most infections within 1 month is caused by the Candida species, especially non-albicans Candida. This organism is generally acquired from the healthcare environment. Beyond that, in 1 to 12 months, most of the infections will be caused by the Aspergillus or the mucor. This is mainly attributed to the immune suppression that is seen over the next 1 year. As far as the bacterial infections are seen, if you see the left hand column, most of the infections within the first month is because of the HAIs. That may be due to the resultant surgery or the invasive foreign body or the catheters that are present, that may lead to infections in the first month. Most of the bacterial infections occur within the first month, and other infections like mycobacterial diseases or nocardial diseases are seen generally about 1 year to beyond that. This is mainly due to the depression of the cell-mediated wing of the immune. Similarly, parasitic infections are more commonly seen in this extended period of about 1 year, also due to the defect of the cell-mediated immunity. Now, having understood this chart, we can appropriately approach the patient and look for the type of the infections that can occur. Furthermore, specific immune deficiency can help us guide to identify the specific infections. For example, if there is granulocytopenia or reducing neutrophil counts, which is also detected by absolute neutrophil count less than 500. If that scenario is seen, we can see most of the bacterial infections and the fungal infections occur in this state. If we look at the defects of the cell-mediated immunity, we will observe that the infections in the bacterial part is mainly caused by intracellular bacteria, including Mycobacteria and Nocardia, and other diseases like Salmonella, Rhodococcus. These can cause the infections. Similarly, defect in the cell-mediated immunity may result in infections predominantly with the filamentous fungi, and as far as the yeast is concerned, cryptococcal infections are very common. If the defect of the immune system is seen in the humoral wing, we can see the encapsulated bacteria cause more infections, and on the same part, patients with absent spleen, either therapeutic or any other disease, that is post-splenectomy, the infections will be more commonly caused by encapsulated bacteria. And I think I have already told you, there is a phenomenon that is called as overwhelming post-splenectomy infections can also be seen. Now, till now we have approached what are the organisms generally causing the infections, how they are associated with different wings of immune suppression, and also what kind of infections occur more commonly based on the time period of the transplantation. Thereafter, if any patient in the post-transplant period is suspected of having infections, how can we approach this patient to detect the infections? So as to approach the detection, first we need to evaluate and recognize the severity of the infection, then identify the source, and then institute appropriate microbial therapy along with symptomatic management, including resuscitation. The most common presentation in this patient would be the presentation with sepsis and neutropenic fever. If that is the presentation, we have to what we do need to do is we need to go through the diagnostic processes as quickly as possible, and as far as the patient with sepsis and septic shock is concerned, we have to follow the same criteria for immune competent patients. The criteria and management are almost similar. What we do need to keep in mind is the specific investigation that we have to get done as quickly as possible. Among them, the most important would be the blood counts with differential. This would help us detecting in absolute neutrophil count less than 500. I've already told you, if that is the scenario, we will looking at some specific set of infections. Along with that, we have to do a comprehensive chemistry panel, urine analysis, and a chest radiograph at the minimum, because most of the patient will end up having respiratory tract infections. Thereafter, we need to do a thorough physical and systemic examination to look for systemic signs and symptoms. And if those signs and symptoms are present, we need to go for microbiological diagnosis based on the type of the symptom that is present. For example, if the signs and symptoms indicate a respiratory tract infection, we need to go for the diagnosis of either respiratory tract samples like a sputum or a bronchial lavage, etc., and may even have to go as far as getting a HRCT of the chest done. Furthermore, in almost all of these patients presenting with fever and sepsis, we need to get a blood culture done, both the parallel for central line and the peripheral line if central lines are already in place, and we need to get the blood cultures done also for fungus, especially for Candida species. Other than that, some of the viral infections are extremely common, which may include influenza infections, herpes group infections, cytomegalovirus infections, and in fungus we can have many very commonly infections caused by Aspergillus species, for which there are many serological markers including the galactomannan acid and the beta-glucan acids. These ancillary tests can also be done for detection of the infection. A very important infection that can occur very commonly is the infection caused by Clostridium difficile, resulting in Clostridium difficile associated diarrhea. For that, we also need to test the stool sample of the patients. Thereafter, we need to administer the empirical antimicrobial agents as quickly as possible. These antimicrobial agents should cover both the gram-positive and gram-negative, including anti-pseudomonas, and this empirical therapy should be tailored according to the local hospital antibiogram. Now, since in these patients fungal infections are very common, we also have to administer empirical antifungal drugs, which may include azoles, and if we do get signs or say are culture positive for Candida, we have to administer antifungal agents like the candin, cyclinocandin or mycofangin or caspofungin. Thereafter, specific other ancillary radiological investigation, including the CT scan either of the chest or abdomen or sometimes even of the head and neck, can be done to localize the infection, especially if infections of the central nervous system is suspected. Many a times, these patients may also end up with what is called as neutropenic enterocolitis, that is the infection of the intestine, and that can also be detected with CT scan of the abdomen, especially in patients who are neutropenic. So, what I want to make you understand is that there is we have to look for the specific signs and symptoms of infection and then tailor our diagnostic process as quickly as possible along with other imaging or radiological evidences. So, to summarize, we need to keep these points in mind. First is patients who undergo solid organ transplantation or hematopoietic stem cell transplantation are medically very complex and they are at risk of infection always, even after the post-transplant period, within 1 month or within 1 year or even after. These transplant patients may present with subtle signs of infections and may also present with atypical presentation of the common infections. So we must be very meticulous in evaluating all signs and symptoms that these patients may elicit. Furthermore, the differential diagnosis in these patients will ultimately be very broad, and our thinking should be very broad in that way. As I've already said, the reason is very simple. the signs and symptoms may be subtle or atypical. And this is further complicated by the immune suppression this patient undergo. Finally, the patients who are critically or may have life-threatening infections should be managed very, very aggressively, both from diagnostic point of view, from therapeutic point of view, and from resuscitation point of view. So these patients are always at risk, and you should always take all the steps to detect the infections as early as possible. Finally, the last part is prevention of these infections in these patients. The prevention can be done by few main points. Keep in mind. First point is reversal of the immune suppression. The team which is performing the transplantation procedure will always try to reverse the immune suppression of this patient, either by stopping or reducing the dose of immune suppressive drugs or stimulating the immunity of the patients. Next step of prevention would be to vaccinate these patients to the common vaccines that are available. And we also need to monitor whether the person has actually detectable levels of antibodies post vaccination or not. And finally, the most important part of prevention of infection in these patients would include the infection control processes that the transplantation team has to keep in mind, especially in case of stem cell transplanted patients. The infection control processes should be robust, would include all type of transmission based protocol prior to the procedure of transplantation, during the transplantation process, and immediate in the post transplantation period. Finally, after the patient is discharged from the process and is sent back to the home, the family or the caregivers of the patient should be made very aware of the proper infection control processes that has to be followed at home also. Along with that, the caregiver should be educated about the various signs of or symptoms of infections that the patient may present, so that these patients can be brought to medical attention as quickly as possible.